Our next subject is fractures, and fractures can be classified by type and cause. In terms of complete and incomplete, complete fractures are broken all the way through the bone, and the bone is split into two distinct parts, whereas an incomplete fracture, there's only a partly broken bone. Displaced fractures occur when the bone is thrown completely out of alignment, whereas non-displaced fractures remain in alignment. You can also have skin integrity involved, as when a bone goes through the tissue, that's considered an open or compound fracture. A closed fracture is when the skin remains intact. We have an image on this slide of an x-ray showing a broken bone or a couple of broken bones. So let's see, based on what we've learned, if we can identify what type of fracture this is. It looks that the bones are broken all the way through. They are no longer in alignment, and it looks as if the bone has broken through the skin also. So that would make this a complete fracture, broken all the way through, displaced because it's no longer in alignment, and it is an open compound because it has gone through the skin. So this is a complete displaced, open tibular-fibular fracture. Fractures can also be classified by cause. A fragility fracture is pathologic or spontaneous. It can be caused by minimal trauma because the bone has been weakened by disease such as bone cancer or osteoporosis. Fatigue fractures can be seen in professional athletes, basically from too much stress on the bone. And lastly, a compression fracture usually happens to older patients with osteoporosis. It happens because of pressure or force on the long axis of cancellous bone found in the vertebra. The different types and causes of fractures are a lot to recall during patient care. What are some simpler ways to identify fractures during a patient scenario? Let's say we are walking to a patient's room and then we hear her screaming, "Help, help, I need help." You find her on the floor after she's tried to get up without help. What are some immediate signs of a fracture? The cardinal signs are crepitus and deformity. Is she guarding a part of her body? Do her limbs look abnormally rotated? Those are the signs that we can look at immediately when we walk into a room. We also have some neurovascular signs if the patient has a fracture that is closed and non-displaced, and we can't really tell immediately that there is a fracture. How are her movements? Passive range of motion, is that impossible? Does she scream in pain? Does she have some swelling at the site? How are the pulses at the site or near the site? Capillary refill, is it quick or is it slow? Her skin temperature, sensations, and pain. All of those things can point to whether there is a fracture or not before we take a patient for imaging for diagnostic testing. Complications from fractures, signs and symptoms of fractures, and how to prevent fractures are when skills of nurses are truly highlighted. We can prevent limb loss, life loss, acute and chronic complications by being vigilant and educated about the signs and symptoms and techniques to prevent complications. Venous thromboembolisms and how to prevent them are a good example. Now, which complication can result from staying in bed for 24 hours after surgery? Venous thromboembolisms, or DVT. The patients at highest risk for getting a DVT are smokers, patients that are obese, or have a general history of being immobile when they were at home. There are some simple measures we can take to prevent DVTs. We try our best to get the patient out of bed post-op day 1 with physical therapy, get them moving, encourage circulation. We encourage circulation also by applying a sequential compression device to their legs and administering a prescribed blood thinner to them in a timely manner after surgery. Acute compartment syndrome is a complication when one compartment in the body reduces circulation to another. And this is when the 5 Ps, knowing the 5 Ps, really comes into play to prevent complications. A nurse can assess that a patient has acute compartment syndrome when the patient reports pain to the site with passive motion. The nurse notices cyanosis or paleness at the site, which is pallor. The patient reports numbness or tingling sensation at the site. It's considered paresthesia. Distal to the site, how are the pulses? Are the pulses faint? Is there pulselessness? That's the fourth sign. Is the limb hard to move? Is the body tense? That's considered paralysis. If you see these signs in combination, you're looking at a patient with acute compartment syndrome, and we need to contact the doctor immediately. Crush syndrome and hemorrhage and hypovolemic shock include blood loss and hemorrhage. And again, we need to contact the physician immediately to resolve that issue. Fat embolism. The sign you're going to see with that are patients with dyspnea, tachypnea, having trouble breathing because they have an embolism. Infection. We can prevent infection post-surgical by administering our antibiotics on time and watching for signs of infection like redness, inflammation, and purulent drainage. Patient can also report pain. Chronic complications like ischemic necrosis and CRPS. Again, we need to be vigilant and watch for the signs of the 5 Ps, which would notify us of CRPS, and then we would notify the physician. Let's see how well we remember our 5 Ps of acute compartment syndrome. What we are checking is a neurovascular status post-surgical. We're going to check if the patient has pain with passive motion. If their skin is pale or cyanotic, that's considered pallor. Do they have a numbness or a tingling sensation? That's considered paresthesia. How are the pulses at the site? Is there a faint pulse or pulselessness? Paralysis. Are they tense or hard to move at the site? That's considered paralysis. Now these are the 5 Ps of indicating that there is a complication in their neurovascular status. We reviewed postoperative care for patients. We should also know how to care for non-surgical management of patients. There are 4 modalities for non-surgical management: immobilization, drug therapy, physical therapy, and nutrition. With immobilization, you're going to want to make sure the neurovascular status is not affected. Bandage, splints, and casts. Also skeletal traction. You want to make sure that these things are not too tight. Bandage, splints, and casts. With plaster casts, you want to use the palm of your hands to handle the cast. If you use the tips of your fingers, you can actually cause some damage to the cast. With skeletal traction, this patient is really going to be in bed, not really out of bed to chair. You're going to be watching for pressure sores. Do some pressure reduction measures. Monitor skin and tissue integrity. Also monitor for any signs of infection at pin sites. Are they clean? Is there any drainage? With drug therapy, physical therapy, and nutrition, you try to combine these 3 to be convenient for the patient and to encourage them to get moving. When you give pain medication, try to coordinate it with physical therapy so they will not be in so much pain when physical therapy comes to move them about. And with nutrition, maybe physical therapy can come when it's a meal time, any meal, to get them into the chair. We try to find ways to encourage the patient, surgical or non-surgical, to get moving to prevent complications. When we talk about nutrition to help non-surgical management of healing a fracture, we have to think about dietary choices for the patient. What we need to help heal a fracture includes protein, calcium, vitamin D, and vitamin K. What can we choose to help heal a fracture, considering what we need? This includes 2% milk, spinach, steak, multivitamins, kale, yogurt, and a cheeseburger. These have the elements we need to help heal a fracture. When we send a patient home, we should send them home with some patient education about the kind of things that they should eat. That would help them heal their fracture. We can ask a dietary staff, a nutritionist, to come and talk to the patient and give some Give them and their family some information about the best things to eat to help with the fracture healing. Let's explore postoperative care a little more. Say you have a patient that has right leg traction. He calls and alerts you that he is in pain. He believes the traction is hurting and not helping him. What are the steps to take care of this patient? The answer is C. We assess the traction, make sure that there is no foreign object on the traction, that the pin sites are clean. You don't see any redness or purulent drainage that would indicate infection. Give the patient pain medication to address their need. Reassess the traction, and then we call and inform the physician of our activities, what the patient reported, what we see, and what we've done, that we gave the patient pain medication. Then we get the orders from the physician and we carry out those orders. Then we document our findings. Surgical management of a fracture can include an open reduction internal fixation, or ORIF, or an external fixator. With ORIFs, a surgeon opens up the side of the fracture and inserts metal pins, screws, or plates to immobilize the fracture. These inserts can be removed or kept in later. External fixators require pins into the bone attached to an external frame. An image of an external fixator has been added to the slide. What you have to consider with ORIFs and external fixators, particularly external fixators, they do reduce the mobility of the patient. The mobility is reduced, which means that you have to watch for bed sores, do some pressure reduction measures, shift the patient back and forth, talk to physical therapy and see if there's a way to get the patient into a chair. You're going to monitor skin and tissue integrity, especially with external fixators, because the pins are inserted through the skin into the bone. You have to be vigilant. Constantly monitor the site for signs of infections, redness, inflammation, especially any sort of purulent drainage. Neurovascular status, the 5 Ps again. Make sure you're watching for the first 24 hours post-surgical, every hour, neurovascular status, and then every 1 to 4 hours after that. There are special considerations when we take care of patients with external fixators. We must acknowledge the emotional toll of having an external fixator. How does the fixator affect the patient's ability to complete their activities of daily living, their ADLs, and how does it affect their emotions? Patients must be encouraged to participate with their ADLs, encourage them to move out of bed to chair, remind them that the fixator is temporary. The fixator is not a fun thing to look at for them. It can be scary, it can make them angry, it can make them sad. They can feel hopeless that they will never recover. So just encourage them to get out, to get moving, do the ADLs, try to establish some normalcy, and remind them that the fixator is temporary. So all this information about osteoarthritis and fractures, it can be stressful to think that you need to know all of this information. What you really need to focus on with osteoarthritis are the signs and symptoms and pain management. Those are your responsibilities as a nurse. Recognizing that a patient has osteoarthritis, such as with the nodes on their hands, Herbedens and Bouchards, and pain management. What are we going to do to help relieve their pain? As far as fractures, you're not going to be performing the surgery unless you decide to pursue that later on. What you really need to know is the signs of neurovascular status, complications, and preventing those complications. That's your responsibility as a nurse. So those are the things that you should focus on, and knowing that those are the things you can focus on should help reduce your stress.